be. So I am clearly not going to cover the entire syllabus in superficial depth. I'm going to try and go into a few topics in a bit more detail. So Toby and I have been through some of the previous pain questions and picked out ones that have been answered poorly. So I've tried to go through a bit more detail on those. I've also had to think about what might be current topics that might come up in the future. So what's going on in kind of the world of pain medicine, which is probably worth reading over because you might not find a previous question on them. I'm also not going to go into any pharmacology or pain pathways or things like that, which are just very dry and something unfortunately you just need to sit down and learn really. So I thought the best place to start is what is pain, and you probably all know the standard definition of pain, but you might not have noticed that actually pain changed last year. So the IASP, which is the International Association for the Study of Pain, redefined pain right in the middle of COVID last summer. So it's now an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage, which is a bit of a mouthful, but I think it's one of those things that you just need to know because you could easily just get asked as a off-the-cuff question in a Viva, what is pain? And basically, in a nutshell, pain is not nociception. Nociception is the physiological process of getting from your nociceptors to your brain. Pain is what the patient is experiencing. So in a nutshell, pain is what the patient tells you they are feeling. Nociceptors are firing most of the time, but this is not always perceived as pain. They undergo significant modulation to what the patient actually feels at the end. So I suppose the only bit that's changed here is that it's the or resembling that associated with actual or potential tissue damage. So it's a tiny change, but it's just worth learning. So let me just quickly go into acute pain versus chronic pain. So acute pain is useful, it's predictable, it has a biological significance in that it's protecting the body. Chronic pain is always pathological. There's no survival benefit to an organism from having pain that continues past the point of healing. So it's basically biologically useless. However, there's not a very good definition of chronic pain, and depending on what you read, you might get different definitions. Some people have tried to put a timestamp on it, whether that's 6 weeks, 3 months, but depending on what you read, you'll get a different answer. The general theme is that chronic pain is pain that continues after full healing of whatever happened had occurred. You can then break down pain further from acute and chronic pain into kind of a mechanism-based classification. So whether that's nociceptive pain, neuropathic pain, visceral pain, functional pain, which is semi-useful, but most pain is mixed. It's not particularly easy to classify, and patients will often look at you like you're completely mad when you ask them what kind of pain they're feeling, or if you ask them to describe their pain. So, as you all know, nociceptive pain is pain that arrives from actual or threatened tissue damage. So that's your activation of your nociceptors. And this tends to be reasonably easy for patients to understand and kind of talk to you about this. They've broken their leg, it hurts, they understand that. Neuropathic pain tends to be a bit harder for patients to understand. And the definition of neuropathic pain is pain that's caused by lesion or disease of the somatosensory nervous system. And the patient will often say that they have burning pain, stabbing pain, lancinating, electric shocks, pins and needles. And that's slightly different to nociceptive, obviously, but these things often overlap. So you can often have nociceptive pain with neuropathic pain and vice versa. They rarely occur in isolation. So neuropathic pain can be spontaneous or evoked. So in spontaneous, there's no obvious peripheral stimulation, and that can be paroxysmal or continuous, whereas evoked is your symptoms of allodynia and hyperalgesia. So again, a couple of definitions. Allodynia is pain from a stimulus that does not normally provoke pain. So patients with trigeminal neuralgia, for example, will say that just touching their face or cold wind or brushing their hair now causes pain. Whereas hyperalgesia is an increased response to a stimulus that is normally painful. So whether that's heat that's not normally painful is now painful. And dysesthesia is just an unpleasant, abnormal sensation, whether it's spontaneous or evoked. And there are many causes of neuropathic pain. If you think of your surgical sieve, you can have entrapment of nerves, so radicular pain from herniated discs. You can have infective causes, so your post-herpetic neuralgias, traumatic, so after phantom limb pain after amputations, metabolic causes, things like diabetic peripheral neuropathy or in HIV or alcoholics. So there's obviously multiple causes. NICE has attempted to, has given us some guidelines on the treatment of neuropathic pain, and they're not particularly in depth. It basically names 4 drugs. They are amitriptyline, duloxetine, gabapentin, or pregabalin, and says try them all. So if you try one and it doesn't work after 3 months or 6 months, then you stop that, you try a different one. If that doesn't work, you try a different one. And once you've tried 3 drugs, you think about referring to secondary care. It says that tramadol is useful in neuropathic pain, but only as a rescue therapy and should never be used regularly. Once a patient gets referred to secondary care, the things that we have at our disposal are things like Cadenza, which is an 8% capsaicin cream, lidocaine plasters, nerve blocks, spinal cord stimulators, pain management programs, those sort of things. So one of the questions that came up a couple of years ago was a question about chronic post-surgical pain, and it was very poorly answered. I think the majority of people failed it. So I'll just go into this in a bit of depth. So chronic post-surgical pain is pain develops and persisted beyond the time expected for the normal healing process. And the time put on for this is approximately 3 months after surgery. And you have to have excluded all other cause of that pain. So make sure there's no malignancy, there's not an infection, there's not a wound breakdown. And on average, about 30% of the patients suffer from neuropathic pain, as opposed to nociceptive inflammatory pain. And the ones that suffer from neuropathic pain tend to have a far worse quality of life, and their pain is much more severe. So the reason that they're quite keen on asking this question is because it's very common. So the most common surgery to get chronic post-surgical pain is thoracic surgery. And I think these are actually quite conservative numbers. So these, this systematic review showed that after thoracic surgery, about 40% of people suffer from chronic pain after thoracic surgery, about 40% after breast surgery, 30% after knee or hip replacements. So they're big numbers. If you think of the burden that puts on the NHS and society, it's vast numbers. That's, if you add all that up, it's huge numbers of patients across the country each year are suffering from pain. So we need to try and work out better strategies to improve that. So the risk factors for suffering from post-surgical pain, so it tends to be young females. There's some genetic link. So if a parent or sibling has suffered from it, then they're more likely to suffer from it. if they've got previous psychological problems, so that's mental health disorders, low mood, anxiety, then they're more likely to. Other risk factors are if they have a history of chronic pain. So whether that's pain at the site of where they're having surgery or anywhere else in the body, they're more likely to get post-operative pain. Other things are surgical technique, so laparoscopic versus open, whether meshes are used, how good the surgeon is, how long the surgery lasts, whether they've had multiple operations. And then post-operatively, you can begin to predict whether they're going to have chronic pain and how intense their acute pain is, and whether they have any post-operative complications or any adjuvant chemotherapy or radiotherapy. And they've tried, so in a nutshell, pain predicts pain. So pre-op pain at the site of surgery predicts post-op pain, and pain anywhere in the body pre-op also predicts chronic post-surgical pain. So it's not just as simple as saying it's nerve damage which causes the neuropathic pain post-op. There's not really any correlation between a transection of a nerve and the development of chronic post-surgical pain. So they've done studies where they've transected nerves and that hasn't necessarily led to chronic pain. There's a large inflammatory immune response leading to a big cascade of neurotransmitters which cause local peripheral changes in the nociceptors themselves and the A delta and C fibers that go to the dorsal horn, and then you get changes in the spinal cord, which I'll come on to in a minute. It's incredibly complicated and there's not very much evidence either way about any of this. Most of the lab data comes from the lab, but what they have managed to work out is that you get peripheral sensitization and central sensitization. I know this is a little bit dry, but there's actually a question which the entire question was to explain the central sensitization in chronic post-surgical pain. So in peripheral sensitization, we're talking about the changes to the nociceptors themselves and their signaling cascades, and that tends to be inflammatory mediated. So there's a whole inflammatory soup. So that's your prostaglandins, leukotriene, substance P, glutamate, potassium, hydrogen ion, serotonin, bradykinin, all that whole inflammatory soup causes all these problems. And it happens incredibly quickly. So you can start getting peripheral sensitization within 24 hours or so. And the end point of all these changes is that your voltage gated sodium channels have a lower activation threshold and increased transmembrane currents, which means that you have more action potentials for your stimulus, i.e. your stimulus, a stimulus that previously wouldn't have caused pain now causes pain. You also have central sensitization, which is kind of known as wind up, which is an activation dependent increase in excitability in the dorsal horn. So the higher surgical stimulus and inputs into the spinal cord, you then get an increase in excitability. And this is an NMDA receptor mediated response. So there's normally a magnesium plug sat in your NMDA receptor. This gets removed, and then you have an increased excitability. You also have your wide dynamic range neurons in lamina 4 and 5, which then get activated, and that then allows your A beta fibers become nociceptive, and that's your secondary hyperalgesia. There's also decreased inhibitory input from your descending inhibitory pathways, and then you get post-translational and transcriptional changes within that, which overall leads to this central sensitization. And I'm sorry that's a bit dry, but I just thought I'd better go into it. You'll send you the slides later for you to read over, but there has been a whole question just on this. So over the years, there's been multiple attempts to reduce chronic surgical pain. They've tried preemptive versus preventative analgesia. So preemptive is where you start the analgesia long in advance of the operation to try and settle things down. So an example of that was in vascular patients having amputations, they would give them an epidural 2-3 days beforehand, load it up, so they were in theory in no pain before going to theatre, but that did not help. And obviously you can think of the workload of going around putting epidurals in people in the ward preoperatively. Preventative analgesia has better evidence behind it. So that's, for example, putting in your nerve blocks, your nerve infusion catheters, your epidurals, and loading them prior to your incision. And the thought process is that you reduce that nociceptive barrage, which leads to your central sensitization. The other things that have been tried are perioperative gabapentin, pregabalin, ketamine, clonidine, magnesium, all of which have been tried multiple times. And as of yet, there's no convincing evidence either way. But I guess the takeaway message is that everything you do is potentially going to help, although the evidence isn't there yet. That's probably due to very poorly designed studies. There are some interesting ideas in the future. So minocycline, which is can prevent the activation of microglial cells, specific sodium channel blockers. So the voltage gated sodium channel 1.8 can reduce chronic pain behavior in rats. So there's lots of things on the horizon, but nothing particularly good at the moment. So on a similar vein, so there's a phantom limb pain question a couple of years ago, which confused people, as people didn't start simple. With any pain question, it's always a good idea just to go back to basics. Don't get worried about what they're thinking. Just go back to basics and keep things simple. So this question, which threw people for some reason, was basically looking for simple things. So failure of analgesia, why potentially does any post-surgical pain patient get more pain? Has their PCA tissue, is the PCA syringe empty? Is the block worn off? Are there any surgical complications? Is there any bleeding, infection? There are pressure effects? Is the bandages too tight? Or are they developing chronic post-surgical pain? So is there an element of neuropathic pain, phantom limb pain perhaps? So after an amputation, phantom limb pain is very common. So pretty much every amputee will have phantom limb sensations. So it's around 90%, 100% of all patients will get the sensation their limb is still there. And for most people, over the next 2 to 3 years, that settles down. However, quite a few are still left with features of phantom limb pain, which is where they still feel pain in the amputated leg or arm. So this picture was drawn by a patient suffering from phantom limb pain. So she'd had a forearm amputation, and she drew this to try and visualize how she feels with her hand that's still there and still painful, even though there's nothing there. So it's more common in legs rather than the upper limbs, and that's partly due to the way that the somatosensory cortex is mapped out. So the lower limb pathways come from the fasciculus cuneatus, whereas the upper limbs come from the lower limbs come from the fasciculus gracilis, and where they map into the cortex is the upper limb is more anterior and has lots of inputs and is related to higher cognitive functions, whereas the lower limb is more posterior and there's less kind of less higher functions. And so lower limb pain is more common. And they can start pretty quickly. It can start just days to week after an initial amputation, and it's more likely in patients that have got preoperative pain, which we spoke about earlier. And the patient quite often describes being able to feel the limb being in an uncomfortable or distorted shape, which is really uncomfortable, well, really painful. And it can occur in any part of the body. So it's not just limbs. So you can have it in patients who had a mastectomy, patients who had teeth out, patients who had their eyes out, and also in patients that have had gender reassignment therapy. So with any sort of chronic post-surgical pain, the idea is the same. So it's trying to control the pain well before the operation, and then using a multimodal technique, making sure you use regional techniques, epidural, lumbar plexus blocks, nerve infusion catheters, and then getting on top of their post-operative pain as soon as you can, and then potentially augmenting that with tricyclic antidepressants, gabapentinoids. Interestingly, one of the few things that actually has reasonable evidence for it is the use of a mirror box. So a mirror box is where the patient will put their amputated limb into a box and then visualize their other limb in a mirror. And this sort of tricks their brain into thinking that that's their hand, and then they can unclench their fist or move their limb into a more comfortable position. And overall, this has been shown to reduce the intensity and duration of their pain. And it's simple, cheap, and pretty effective. So I thought cannabinoids are quite topical. I don't think there's been a question on this yet, but I suspect there will be soon enough. So I was just going to go quickly through the nice guidelines for cannabinoids and also how they actually work, or how we think that they work. So basically, like I said, don't use them for pain in a nutshell. You can use them if they're part of a trial, or if a patient's already on been prescribed CBD previously and it's working, they are allowed to continue with that. There are two main endogenous cannabinoids in the body, AEA and 2-AG, and they interact with your CB1 and CB2 receptors. Then from the cannabis plant, you have phytocannabinoids, and that's your THC and your CBD. And then there are some synthetic ones that have been produced. So the cannabinoid system is a retrograde neurotransmitter pathway. As I said, there's two main receptors, they're CB1 and CB2, and they regulate glutaminergic and GABA signaling pathways. CB1 is the more important one, and that's found throughout the body and the CNS, and is especially closely linked with pain modulating pathways throughout, really. So that's primary afferent neurons, dorsal horn, descending inhibitory regions, periaqueductal gray, whereas the CB2 receptor is far less common, is thought to be more associated with the immune response. They're also, the CB1 receptor is also linked to pretty much every G protein coupled receptor you've ever heard of, including opioid, serotonin, muscarinic, dopaminergic receptors, and there's some sort of allosteric modulation of these receptors, but they're not entirely sure what the mechanism or how they work. So your endogenous receptors are responsive to your external cannabinoids, and they are the THC and CBD. In the plant form, they're completely inactive, and you have to have the addition of heat to activate them. Hence why people smoke or vape or bake cannabis. THC has been reasonably well investigated. It's anti-inflammatory, analgesic, sedative, and they've mapped it out quite well. People haven't looked at CBD quite so much, and it's thought to be an anti-inflammatory and possibly an analgesic, although the evidence isn't quite there. THC is the one that tends to give you your neuropsychiatric effects, so people are trying to prescribe CBD with THC, to prevent those side effects. So in terms of the evidence for cannabis use, there isn't good evidence yet that we should be using it. In experimental pain models, looking at pain threshold using an electrical or heat stimulus, some studies showed an increase in pain threshold, some showed a decrease in pain threshold, and some showed no change. There's been a few clinical studies, but they're all pretty poor. In acute pain, there's 7 studies. Most of them showed no difference. One showed that it worsened pain, and one showed that it improved pain. In the study where it improved pain, it was only as effective as codeine. And in chronic non-cancer pain, again, there was a trend that it improved pain, but on the whole, it was quite inconsistent. You needed to treat 24 patients with the drug to get a 30% reduction in pain, which is pretty poor. Just quickly, the main side effects of cannabinoids, the ones that everyone worried about, is something called cannabis use disorder, which is basically a medical terminology for getting addicted to cannabis. It's not more complicated than that. There's also a worry about psychosis and mood disorders, although the link with that is actually quite complicated. You need to be aware that you can't give it to everybody, so you can't give it to people under 25 years old, can't give it to pregnant women or women who are not on contraception, can't give it to people with schizophrenia or serious cardiovascular, renal or liver disease. And then there's a list of side effects there, which you can probably learn later. I won't go through them now. So the next thing I was going to move on to was a bit more about opioids. So not necessarily the pharmacology of them, but perhaps in unusual cases or when other routes that have come up previously. So a few questions have been about how do you manage patients that are taking long-term opioids and their acute pain when they come into hospital. So the main aim when someone comes in on opioids is to control their pain without causing withdrawal symptoms or overdosing them. And patients come dependent on opioids pretty quickly. So you only have to be taking codeine or tramadol, not even at the maximum dose, for 2 weeks, and you'll notice withdrawal symptoms when they come into hospital. And it's reasonably easy to prevent the withdrawal. On the whole, you only need to have about 50% of their usual dose is enough to prevent them withdrawing. So when anyone comes in, you need to calculate their total opioid dose to see how much they're going to get in a 24-hour period, and then make sure that they get that, whether it's through a PCA or slow release morphine, but just make sure that's the minimum dose they should be getting, and they'll need acute pain relief on top of that. Encourage the patients to take their usual opioid dose pre-op, just so they've got that baseline there that they're used to. In terms of patches, so buprenorphine and fentanyl patches, there's, depending on what you read, tells you to do different things. So some people say remove the patches so that you can control what they're getting. The risk of this is that they withdraw and you don't give them enough. The risk of leaving the patch on is that people don't know it's there and they overdose, or if you put them in theatre with a bear hugger or a heating blanket, then that can increase the amount of opioid release from the patch, and you can overdose them that way. All the studies show that if they're getting intrathecal opioids through an implanted pump, then that needs to continue. And the technique for anybody is very much the same. So it's a multimodal technique. So think about nerve blocks, nerve infusion catheters, give them a PCA so they're in control of their opioid requirements. And then all the usual adjuvant medications like NSAIDs, clonidine, ketamine, magnesium. Patients taking opioids, regardless of how they're managed, do have higher pain scores, so they need a very thorough assessment of their pain. people, or there's a bit of a stigma around people coming in on opioids, that they're addicted and they took their drug seeking behavior rather than actually being in pain. Also, try not to discharge anyone on increased doses of opioids. Try and get them back to their baseline level before they go home, and try and get a pain team or a drug team in early on to help with the management. The Faculty of Pain Medicines had a campaign going for a couple of years called Opioids Aware, which is worth knowing about because it could easily come up, and it's basically trying to get clinicians to reduce the amount of opioids that are used in the community. And this basically has come around from the overuse of opioids in the US and Canada, which has led to a huge socioeconomic burden and a lot of avoidable deaths. So basically, opioids are very good for acute pain and they're very good in palliative care, but there's very poor evidence for their use in chronic pain. So they should really be stopped in people with chronic pain. A very small proportion may get some pain relief, in which case they can continue taking them, but they're much more effective if they're used at a low dose and used intermittently as a rescue therapy rather than taking the same dose every day. They've put a figure of 120 milligrams a day of oral morphine equivalents as where your risk substantially increases. So above 120 milligrams a day, you're 8 times more likely to die each year than someone who's not taking opioids. But despite higher doses, there's no actual evidence that they have an increased benefit. And so in a nutshell, if patients are on high doses of opioids and they're still in pain, then the opioids should be stopped, even if nothing else is available. A couple more definitions, because again, these have come up previously. So addiction is a disease. It's compulsive use of a drug that's continued despite causing obvious harm, and the patients have craving for it. Dependence is a patient needing to take the drug to avoid withdrawal symptoms. And so they'll be aware of that because they know that if they miss a dose, they suddenly start getting feeling unwell. Tolerance is different in that it's where your body's adapting to the drug, and so you're needing higher doses for the same effect. Pseudo addiction is drug-seeking behavior, but due to increased pain, and this can often happen in palliative care patients as their cancer's progressing. And one of the worst things is when these patients get put down to being difficult or drug seeking because they're addicted to their morphine rather than actually trying to help them. I'll just quickly go through dose equivalents because again, this has come up. So there's very little good data about how to change between opioids. There's a lot of inter-individual variation and poor data. So all the conversion factors that you can see are very approximate. You need to be very careful changing from one to another. And it's always sensible to reduce your converted dose by at least 25 to 50%, especially with higher doses of morphine. And you need to just think about the half-life of the drug you're changing and the speed of onset to avoid toxicity or breakthrough pain. So I've put these in. I just learned them. I think I'm not going to go through them now. Again, I've talked about the differences between IM, IV and subcut opioids, which are probably just worth having a look at because again, these things have been asked. But as we push for time, I'm just going to keep going. Okay, so again, there was a whole question in the science part of the Viva about intrathecal opioids and purely about the mechanism of action of the opioids. which I think is a little bit unfair because it's ridiculously complicated and very poorly understood. So no one truly really knows how they work. There's lots of theories. So they have lots of different effects. They work on your opioid receptors in the lamina 1 and 2 of the dorsal horn. They cause potassium channel opening and calcium channel closure, which leads to a reduction in intracellular calcium, leading to a reduced release of your excitatory transmitters. It also has effect on reducing your GABA and glycine release, which is counterintuitive, but it's thought to be disinhibiting your descending inhibitory pathways. So by reducing your GABA and glycine, you're then increasing the activity of your descending inhibitory pathways. Fentanyl is unusual because it also has a local anesthetic effect on your direct effect on your C fibers, as does pethidine actually. Okay, so then they asked about the how using different opioids in a spinal anesthetic can change the effects. And this is going back to the basics, pharmacodynamics and pharmacokinetics. So if you decrease the how lipophilic a drug is, you increase the duration of action. And if you make it more hydrophobic, you increase the potency. So that's kind of comparing fentanyl and morphine intrathecally. Fentanyl's 4 times more potent intrathecally as opposed to 100 times if you use it IV compared to morphine. And they've tried to model the way that opioids are distributed throughout the CSF, but it's very difficult. So models assume that you've got complete mixing and equilibrium across all compartments, which doesn't happen in the CSF. But overall, you have a cephalad flow of opioid due to lots of different effects. So bulk flow, fluctuating pressure in the thorax when you're breathing, and then brain expanding and contracting due to the cardiac cycle. I'll leave that now. So I'll just move on to drug patches quickly now, which again, they asked a lot about recently. So opioid drug, or not just opioid, sorry. So transdermal drug delivery systems are very popular. So it's worth noting that it's not just analgesics that are used. So the first things that come to mind are fentanyl and buprenorphine, but also think about HRT, contraception, clonidine has been used in hypertension, scopolamine been used in motion sickness, you've got nicotine, there's drugs in Parkinson's disease. So if you ask for examples of patches that you might come across in theatre, don't just think about the obvious ones. And the way that they work is the patch is applied to the skin, you create a concentration gradient, second reservoir and concentration gradients then established in the stratum corneum, and then the drug is then absorbed from the capillary beds in the dermis. And there's 2 main systems, a reservoir and a matrix system. In the reservoir system, there's just a gel of drug with an overlying membrane which controls the release of the drug, and a matrix system where the drug is kind of interwoven within the actual matrix, so the adhesive part of the patch. The matrix tends to be safer because with the reservoir, if you cut that membrane, you can have a bolus of drug. And there's also been cases where patients have aspirated the drug reservoir and then injected it from the reservoir medications. And from the pharmacal properties of drugs, they need to be very lipid soluble and have a low molecular weight. So all the drugs we have that are used, so mainly fentanyl and buprenorphine, have a low molecular weight, less than 500 daltons, and that's just to allow them to get across the skin. So the benefits of it are that it avoids peaks and troughs. Patients quite like them, so they have much higher compliance and they have much lower side effect rate due to not getting the peaks that you do. Yeah. So you might get asked, what do you do with a patch? So as I said earlier, you can leave it on or you can take it off. It sort of depends on the patch and what they're having done, how long they're going to have surgery for, obviously all the different factors with that. In terms of whether buprenorphine has an effect on your opioid requirements, they're probably not. So you can keep a buprenorphine patch on, although it's a partial agonist, it's not going to affect how much drug you're going to need. You don't tend to get an effect, an antagonistic effect until 16 milligrams a day. And the most you could ever get from a buprenorphine patch is about 3 milligrams a day, and that's putting on 2 of the max dose patches. Yeah. Okay, so yeah, so like I said, so you can leave them on or you can take them off, try and maintain what they're usually taking and try and keep it on. It's quite likely that if you remove the patch, you're going to be a bit of a loss in the post-op period about their opioid requirements. They're still going to have a lot of opioid in the reservoir in their skin, which may take 24, 36, 48 hours to be released. So it's quite likely they could withdraw in the post-op period. Just very finally, just before I finish, I just want to mention pain management programs quickly. As they are kind of the end of the line for patients that come to chronic pain clinics. They are multidisciplinary sessions where the patients will come along. There'll be a psychologist, physiotherapist, nurses, doctors, an occupational therapist, and it's kind of group therapy over about 10 weeks. They normally have 3 hours a week. And that is probably has more evidence in chronic pain than all the other things I've talked about, whether that's nerve blocks or medications. And it's the aim that we are trying to improve quality of life rather than just looking at pain numbers and trying to reduce their pain scores. But that has previously come out as a question to talk about pain management programs, so I'll put it in there. And then other things at the end, I just thought you might want to make sure you look at, which might be a bit off-piste, would be pain assessment tools. So thinking about the McGill pain question, visual analog scales, the Abbey pain scale, FACES scale, things just to be able to talk about them. And then how TENS machines work and the indications for them, spinal cord stimulation, spinal cord stimulators, and chronic regional pain syndrome. So that is pain in a nutshell. It's a bit of a whiz through. I'll send the slides out because I skimmed over quite a lot and there's quite a lot of dry topics in there, which is probably best reading in your own time. So Toby, have you got any questions you want me to ask quickly?
Hi, Andy. We've had none through yet, which is absolutely fine. I think people were probably more likely to email them through to us. Just want to say enormously thank you very much indeed for a fantastic talk. Mate, I'm just gonna, I think if we try and I'm going to switch you off somehow.
When you want me to stop sharing?
Yeah, is that all right, mate? Perfect. Guys, I just want to say, Andy, thank you enormously for that talk. That was brilliant. It's actually a huge amount of detail and makes me realize quite how much I might have forgotten since I did the final. Like I say, if you want the slides, please just email us, just because there is, as Andy says, a lot of detail that we can obviously send through to you guys. And I'm going to try and get that video up later on in the week, as soon as I figure all that out. Thank you very much indeed. Tomorrow we've got Dr. Rich Armstrong talking about mainly guidelines and notable studies and other bits and bobs that are actually going to be quite pertinent and helpful just to kind of skim over for the SOE. So things that might be quite helpful that you might not have touched on. So if that's going to be helpful for you, please check in again at 7 o'clock and we will see you then. Very nice to you guys. I'm going to
Have
hand
a good
this
evening,
now.
guys.
See you later all.
Take a break.
Thank you very much. It's very nice. Thank you.